Okay, so good evening again. Welcome to the ECG lecture series. I'm Dr. Alistair Sandilands. So we're on to lesson 4 now. So on to tachycardias, and I've tried to split those up into narrow and broad. So next week we'll do broad tachycardias before the last lecture, which is sort of a revision session on cardiology. So again, I stress the importance that don't worry about how you're learning ECGs. You're going to learn at different paces. It's a very difficult skill to become a master. But like I said in the past, practicing ECGs will perfect things and help you. So sometimes it helps to have context, especially if you're in the clinical years compared to the preclinical years, but it can confuse. But we'll go through some more ECGs this evening. So what we want to do is identify what we call narrow complex tachycardias. Narrow complex means that the QRS is narrow, and that means something. And we'll go through the causes. So some of them may be focal, certainly in an atrial tachycardia. There could be something called a reentrant mechanism, as it re-enters from the ventricle to the atrium and back down to the ventricle again. Possibly some scar-related rhythms, and some that might be life-threatening. So again, I want you to try and understand the key concepts relating to the signals. So we'll have a review of the signals that are pertinent towards tachycardia and the algorithm that I've got for tachycardias. And of course, I want to be able to improve your confidence at ECG interpretation, and I'm hopefully it's working so far for you. So this evening, we're going to go through some signals that are pertinent and what you need to be looking for when going through the algorithm. We're going to look at what we call supraventricular tachycardias. Supraventricular means they originate or are using the atrium. So atrial fibrillation, atrial flutter, atrial tachycardia, and narrow complex tachycardia. I suppose within that, actually, there might be sinus tachycardia, which is a form of atrial tachycardia that originates from the sinus node, could be included there. So remember, when I mean narrow, I mean the QRS is narrow, less than 3 small squares, and you could put a pencil over it, for example, and you'd cover up the QRS. When it's broad, it's possibly relating to the presence of bundle branch block, which we'll actually cover next week under broad complex tachycardias. And obviously go through my algorithm that we've got for narrow complex tachycardias. Again, we'll go through some examples, trying to build into what the tachycardias are with the pertinent signals. And at the end, we'll end with Kahoot. So there's 32 questions tonight on Kahoot, and I've sent you some of the ECGs to look at already. Okay, so what are the signals that are important to tachycardia? So first of all, the P wave is important. Is there a P wave present? Does that mean something? So the P wave may be focal and therefore discrete. And what I mean by that, you can see here, okay, so this is just a tracing of P wave asystole to try and show you what the P wave looks like alone. So you understand what I mean by being focal and discrete. This P wave is focal and discrete. It's on its own. Then the next one comes along, and this is a slow rhythm, yes. In a tachycardia, these P waves might be coming more regularly, but you can see that in all the 12 leads of the ECG, if you have an ECG showing an atrial tachycardia, the P wave will be discrete. Okay, so that's the first one. The P waves may be continuous or fluttery. So now this is a rhythm strip of lead 2, where the patient has either done the Valsalva maneuver or they've been given adenosine to take away the QRS signal. So you can still see here that the fluttering is occurring with the QRS, but the fluttering continues, the QRS goes away, and now there is just continuous fluttery wave here, indicative of atrial flutter. And you can see the difference here. Whilst this is a wave, it is continuous, fluttery, but not like discrete, stops, and then another one occurs, stops, and then another one occurs. This is continuous movement. So that why it explains the two rhythms. Say an atrial tachycardia or sinus tachycardia originates from a focal point, so the P wave will be focal and discrete, and it will fire down to the ventricles. I know it's not showing it here, but down to the ventricles and then the next P wave will occur fired down to the ventricles. In this situation, it's a continuous movement around the atrium. A flutter is called a macro re-entrant rhythm, traveling around the atrium and then depolarizing down to the ventricles via the AV node. So this is focal, discrete, this is continuous and fluttery. Compared to what I call fibrillatory. So we've tried to look at an ECG with atrial fibrillation with the conduction, best seen perhaps in leads V1 or the inferior leads, where you've got a very wavy baseline. And this is what we call atrial fibrillation occurring. Okay, and there's the conduction to the ventricle as judged by the QRS. Okay, so that's a different sort of P waves that we're looking for. Is the atrium involved? Is there, P waves discrete? And I'll show you some examples. Is it continuous or fluttery, suggestive of atrial flutter? Again, you look at the inferior leads to see this sawtooth pattern in the best way. Fibrillatory, V1 is the best place to look at. Okay, so one of the first things to do is we're looking at the rates. And so obviously, sinus tachycardia is originating from the sinus node, depolarizing to the atrium. You've seen this before. The rhythm goes into the AV node, which is your PI interval. Depolarization goes beyond the AV node, down the bundle of His to supply the right bundle branch and the left bundle branch. Okay, so how do we define a tachycardia? We're looking at around 110 to 120 beats for it to be classed as a tachycardia. And one of the ways of looking at this is to count the number of QRS signals in the rhythm strip, which is 10 seconds, and then times that by 6 to get your number of heartbeats per minute. So this is an example of sinus tachycardia. So there is some artifact here, but you can see that along the rhythm strip, there is a clear P wave, discrete and focal, conduction to a narrow QRS, and then it beats again, a focal P wave with a narrow QRS. So again, this would be a narrow complex tachycardia, which means that conduction from the AV node down is normal. And it's being fired by the sinus node as a form of atrial tachycardia arising from the sinus node. Down the AV node, bundles are working properly, therefore we have a narrow QRS. So any tachycardia that comes down this way to the AV node and bundles are working properly, then you should see, down this way, should see a narrow QRS, narrow QRS. Any questions about that? Just admitting somebody else. Okay, so I'd like to show you these ECGs more in preparation for next week. When the bundles aren't working properly and we have a rhythm, even in tachycardia, we can see that there may be a broad QRS. So again, we've talked about this ECG. I show it to you every week, so you make sure you get used to the pattern. So if we went through our basic algorithm, we would not see that the QRS is prolonged. And if you just turn off your microphones for me, please, thank you. In V1, if we're looking, we see a negative deflection below this is the isoelectric line. So negative deflection, a broad QRS. Okay, then we just looking at V1 alone, we see that this is left bundle branch block, but it's sinus. I'm just showing you the shapes again, just to remind you what the shapes look like of the QRS signal. This is definitely just sinus rhythm. There is invariably left axis deviation with left bundle branch block, as evidenced by the AVL being the tallest positive lead. And the transition or doesn't become positive normally until around V5 or V6 in left bundle branch block. So the point about this is that you can get tachycardia in someone who's got left bundle branch block. You can get tachycardia in the same way, but obviously it's got a broad QRS. Okay, so you see the pattern of left bundle branch block. That becomes more pertinent next week when we do those ECGs of broad complex tachycardia, but it's just showing you. Alternatively, the ECG may show another QRS that's prolonged. So we go to V1, yes, it's very prolonged, greater than 3 small squares. The deflection now of the QRS goes above the isoelectric line. There's the isoelectric line. And in particular in V1, there's these bunny rabbit's ears. We have a small bunny rabbit's ear, big bunny rabbit's ear, and that's suggestive of right bundle branch block. So how do we confirm that? In normal right bundle branch block, there is slurring of the S wave in AVL and also in V6 to say, yeah, okay, that is right bundle. But really, we're looking at the signal in V1 with the bunny rabbit's ears, with a small bunny rabbit's ear first and the big one afterwards. That's much more suggestive of right bundle branch block. So to recap, in V1, we have a very negative deflection for left bundle branch block. And when in V1, we have a right bundle branch block with the bunny rabbit's ears, small little blip and a big blip, which is right bundle branch block. Okay, so the other ways that we can get tachycardias. So this is just a sort of pictorial diagram of showing you how electricity flows from the sinus node down to the AV node, down to the bundles and back up to the ventricles, and then also across to the left atrium here. And these are just depicted pulmonary veins draining the blood back from the lungs. So in this situation, we have sinus rhythm with a P wave, a narrow QRS, P wave, narrow QRS. This is just normal sinus rhythm. Sometimes, though, there can be evidence of what we call a drawbridge or a connection between the top and the bottom of the heart. Okay, so in this example, this is where you can get something called a reentrant rhythm. So normally, this is where the electrical signal will stop. There is nowhere else for it to go. It will just stop. In this example, electricity flows down, up in the muscle and goes across the drawbridge, the pathway, back into the atrium, re-entering the atrium, and then coming down again to the ventricle. So reentrant, this is a reentrant rhythm. So in tachycardia, because it's going down the AV node and down the bundles, in tachycardia, we have a narrow QRS and a fast tachycardia, okay? A regular tachycardia as well. In a normal rhythm, if the sinus node fires and goes down this pathway, just in normal rhythm, down the pathway and down the AV node at the same time, we have something called Wolff-Parkinson-White, where we have a short PR interval, very short, and we have a slurring of the S wave here, and this is a delta wave indicative of Wolff-Parkinson-White. Any questions about that? Okay, so let's try and think about some concepts now of narrow tachycardias, where it can be broad, and then we'll talk a little bit about Wolff-Parkinson-White again, where it's narrow complex, where it's broad complex, and then something where it's pre-excited atrial fibrillation, where it's atrial fibrillation conducting down the pathway to the ventricle, which we'll confirm next week. Okay, so okay, so hopefully you can see all this now. What are the rhythms that we can see? So atrial flutter, let's see, atrial flutter travels around the right atrium in a counterclockwise fashion. Okay, so here's the AV node here. There's the right bundle that goes down here, left bundle that goes down here. So as I showed you, if you look at this macro reentrant flutter traveling around, if we just looked at the flutter alone, we just see a continuous flutter wave. That's just on its own. Now, if we superimpose the flutter going down into the AV node, down the bundles, we can superimpose a different color. So that we can say this is our QRS signal. Okay, I'm going to put the QRS signal sort of every 2 beats roughly. Okay, so basically, the flutter travels around at 300 beats a minute. So every flutter wave is 300 beats a minute. Okay, and so we superimpose that. So if we put this all together, we have the QRS now here, and the T wave. Sort of put the T wave on top, another QRS here, the T wave, another QRS here. So you have to imagine that the flutter wave is traveling through continuously. The best lead to look at this is in the inferior leads. Okay, so that's a continuous flattery wave. If we have, if we have something that's focal, for example, let's just say we've got the pulmonary veins here. Okay, pulmonary veins here, the muscle of the heart envelops the veins here. Say we have a beat that's coming from here. So it triggers into the atrium, okay, and then goes down the AV node. Here's your AV node, and these are your bundles, right and left bundle. So if it's coming from the pulmonary vein, what we'd expect to see is a discrete P wave, so firing, okay, depending on the shape and which lead it is. Okay, a focal discrete P wave, which is the firing here of the, let's try and do that in green. So now it's coming from the pulmonary veins, it's positive, discrete, and it stops. Okay, and before the next one fires, it keeps firing. It goes down to the AV node. So we have to then superimpose our QRSs again on here. Okay, so this is evidence of our atrial activation, our P wave, focal P wave, discrete, it's not continuous or fluttery, and then conduction down to the ventricles, which is generated by our QRSs here. Okay, so that's an example of an atrial tachycardia, So in all those two, in atrial flutter and atrial tachycardia, the rhythm will be regular. The rhythm will be regular. Okay, so AV node again. Okay, so we have atrial fibrillation. Atrial fibrillation normally originates from the left atrium, It's a very fast chaotic rhythm, so I draw it like this. So the atria are fibrillating. Okay, so they're fibrillating very fast. Again, they're fibrillating at 300 beats a minute. But it's completely chaotic and irregular. So when you look at the rhythm, we've got a wavy bass line. It's not discrete, it's not focal. V1 is probably the best place to look. We've got the wavy bass line as the atrial fibrillation conducts through the atrium, and then it conducts to down the AV node, down the bundles. But of course, the rhythm, the connection of, because the AV node is a three-dimensional structure, because the AF is irregular, the wavefronts hit the AV node in different positions. And so what you get is you get an irregular rhythm. So the QRSs and the heights of the QRSs, I'm talking about the heights here along the baseline, in fast atrial fibrillation can vary, okay? So you're looking at the heights here in atrial fibrillation can vary. That can be a signifier that there is an irregular rhythm, atrial fibrillation. So if we superimpose those in V1, you have the wavy baseline, the irregular rhythm, the absence of P waves, so there's no definite P waves, and irregular rhythm, and the varying QRS, the variable QRS heights. Okay, so this is atrial fibrillation. Any questions so far? Okay, and lastly, we'll talk about the reentrant rhythms. Okay, so one reentrant rhythm originates from around the AV node. Okay, so the AV node is, if it's split in two, so we're taking this AV node now, we're taking the AV node into two parts. Okay, there is one called the fast pathway and one called the slow pathway. So 50% of us have an AV node that's split in two. We don't need the slow pathway. So the conduction, as it means, is going slowly down this channel, but faster through this channel. You need the fast pathway to speed up your heart as you exercise. And then it obviously then goes down the right bundle and the left bundle, just like this. Okay, so the AV node is split in two. Okay, so what happens is during a tachycardia, which is a reentrant, it goes down the fast pathway, back up the slow pathway, and goes around like this. So it goes up to the atrium, and then it goes down to the ventricles down the two bundles like this. So it's re-entering, okay, down the fast, back up the slow to the atrium. So around here, back up to the atrium, back down to the ventricle, oops, via these two bundles. And so what you see is you get simultaneous atrial and ventricular activation at the same time. So it goes atrium and the ventricles at exactly the same time. So invariably, you have a tachycardia and you really don't see any P waves. It's just QRSs that are the same height. I'm not drawing it very well, actually. I need to show you the ECG examples. So you have a regular rhythm and a very narrow QRS, which all the heights look the same. And it's a regular rhythm. And you don't tend to see any P waves. So the heights of the QRS should be the same. They all look the same. And this is an example of a narrow complex tachycardia, or in actual fact, this is called atrioventricular nodal, because this is the node, reentrant tachycardia. AV nodal reentrant tachycardia, AVNRT. And lastly, where else can we have a reentrant rhythm? So there's only two reentrant rhythms. So invariably on the lateral mitral valve annulus, so this is the mitral valve here, there is a connection in patients with Wall-Parkinson-White, allowing electricity to flow in probably two directions. So the sinus node can go to the AV node, down the AV node, but it can also travel down this pathway. Now this pathway normally is what we call a superconductor. It's very quick at conducting. So when the signal goes down in a normal rhythm, we have a short PR interval, and we have a slurring of the S wave before we go to the QRST. Okay, so the PR interval is very short. This is the delta wave here, which is just signifying conduction down the pathway. So you only see delta waves when conduction goes forwards over the pathway from the atrium to the ventricle, only in this direction. So if we change color, if we have a tachycardia for this patient that generates from an extra beat, goes down the AV node, down to the ventricle, and then it can actually go back up the pathway, allowing electricity to flow this way to re-enter the atrium, hence a reentrant rhythm. Okay, so in blue, we will have a narrow complex tachycardia. There are no delta waves now. There are no delta waves at all because the rhythm's going backwards this way. So we just have, again, a regular narrow complex tachycardia. There may be some P waves possibly buried here, signifying conduction back to the atrium, possibly. Invariably, you don't necessarily see them. The QRSs look at all exactly the same, so there might be a P wave there, and the heights of the QRS are the same as well. Okay, so this is a reentrant rhythm, and in the presence of Wolff-Parkinson-White. Okay, any questions about that? Okay. We'll just go back to the lecture. Here we go. Okay, so we've gone through some concepts, narrow. We've talked about Wolff-Parkinson-White, where it can be a narrow complex tachycardia. So let's just look at some examples now. So first of all, so concentrate now on the left-hand side, which are tachycardias that are narrow. Okay, so the first question you look at when you've got a tachycardia, when you judge by the rate, switch to this algorithm. The first question we're asking, is the QRS narrow? Okay, so narrow QRS. Then we have to ask ourselves question 2, what is the rhythm? Is the rhythm irregular or is it regular? Or it could be regularly irregular due to variable conduction to the ventricle of atrial flutter, for example, or atrial tachycardia. So I'll show you an example. So it's either regular or irregular. If it's an irregular rhythm, there are no P waves or variable QRS amplitudes with no P waves, then we have something called atrial fibrillation. Okay. If the QRS is narrow and regular, or perhaps regularly irregular, then there may be variable conduction to the ventricle. Are there any P waves? That's the next thing. So there's no definite P waves. You're not sure they're P waves. So we're looking therefore at something called a narrow complex tachycardia, which, as I've tried to explain, could be AV nodal dependent in the middle of the node, or it could be AV reentrant tachycardia, which was the one with the Wolff-Parkinson-White pathway, but these are narrow complex, less likely to be ectopic atrial tachycardia, which is where there is discrete and focal P waves. So if there are definite P waves and they're discrete, it could be sinus tachycardia, because it could be the P waves could be the same shape across the ECGs, the 12 leads as sinus rhythm. The next thing it could be is an ectopic atrial tachycardia could be next, and less likely the AV reentrant tachycardia, which is the Wolff-Parkinson-White ECG during tachycardia. So if the rhythm is narrow, regular, definite P waves, so look in the inferior leads, 2, 3, and AVF, and you see a continuous and regular sawtooth pattern, therefore we have atrial flutter. Okay, so don't just forget this side, we're going to do that next week. So we're looking at QRS being narrow. Is the rhythm regular or irregular? Are there P waves? Are there any other features that tell you that it's these 3 things, sorry, 4 or 5 things? I'm going to have a look at that with some examples. Any questions about this? Okay, so I'll just get you to look at some of these ECGs. I'll give you some time to look at this first one. What causes someone to have a Wolff-Parkinson-White ECG? Yeah, good question. Basically, patients are born with this connection between the top and the bottom of the heart, the delta wave. They're born with this. And for some people, it causes problems. It can end up causing sudden death in about 1 in 1,000 patients, probably a slightly 1.5 patients in 1,000. So we diagnose it because they have an ECG routinely if they don't have symptoms, or they get the symptoms of palpitations. And then when they're back in a normal rhythm, you see the delta wave and make the diagnosis of Wolff-Parkinson-White in conjunction with their symptoms of palpitations. And it ranges from patients. So I've seen patients as young as 5, 6 with Wolff-Parkinson-White, and I've treated patients in their 80s with Wolff-Parkinson-White. So it's strange how they present at different ages. Okay, so this example, we have a tachycardia. There's no rhythm strip. So we can't quite work out the rate, but we've got about 2.5 squares. So you're looking at a rate about 130 here. So we know it's a tachycardia. So we ask our questions. It's a tachycardia. It's a narrow QRS. So that means conduction down through the AV node to the bundles is normal. Do we see any P waves? Yes. What do the P waves look like? They certainly look focal and discrete everywhere. So we're looking, especially in the inferior leads, just make sure that the P wave is focal and discrete, yes. But if you look at the shape of the P waves throughout, apart from AVR where it should be negative, the P wave looks positive everywhere. And this suggests that this is sinus tachycardia, okay? So P waves focal and discrete, sinus tachycardia, it's the same shape as in sinus rhythm. But it's a 73-year-old man with pneumonia. So he's got pneumonia, he's tachycardic because of that. Yes, there is also left axis deviation. And yes, there is also poor R wave progression till V5, but this is not left bundle branch block. It's a narrow QRS sinus tachycardia. Okay, so I'm going to talk to you about this one because I'm just asked you a question. So let's concentrate on the rhythm strip. So I want to try and explain to you a concept to try and understand about tachycardias. If you look along the rhythm strip, okay, sorry, why wasn't that one left bundle branch block? No problem at all. Let's go back. Because the QRS is narrow, it's not greater than 3 small squares. So if we go back, look at that. This is where left bundle branch block is very broad. Okay, so we're going from there to the start of the S wave. It's definitely greater than 3 small squares. Whereas this one is not. It's bordering on it, yes, but it's not quite complete left bundle branch block. Okay, whilst I take it that it's got the same pattern, it's not quite 3 small squares. Okay, so when we're looking along this rhythm strip here to try and understand what bits of the signals look the same, ask yourself what looks the same on all of these beats, exactly the same. So what looks the same is the QRS and then the T wave, the QRS T wave, QRS T wave. They all look the same shape, same height. They all look exactly the same. So what does that suggest to you? That suggests that conduction from the AV node down on all of these beats is the same. It's common to all of them. Now, if you look along, what is not the same? What can you see that might not be the same? It's the P wave. So now we've got a normal P wave going down to the ventricles, QRST, and then we've got a negative P wave here, okay, to the QRS. And then we've got a pause, heart resets itself, P, QRST, and then a P that's a different shape. That's a different shape to that, but this is a different shape to the negative P wave there. Okay, so P, QRST, P, QRST, another pause, P, QRST, again, another P wave here that matches this one, but doesn't match this one. Okay, and now PQST again, the P wave that now matches this one, but not that one, that's flatter. And normal, just one beat on its own, and then again, PQST, and then another beat. So we've got conduction down the AV node, every single beat exactly the same, but we've got the origin of the beat from the atrium, the focal P wave, being different. So what we have is this is the normal beat, and this is the atrial ectopic. And after an atrial ectopic, we have a compensatory pause. The heart pauses to reset itself. Sinus node fires again. And we've got a different focal discrete P wave here. Again, resets itself. So we have atrial, a period here of atrial bigeminy. So bigeminy means every second beat there is an ectopic. Bigeminy, every second beat there is an atrial ectopic. So this is atrial bigeminy. We have a regular, irregular pulse, regularly irregular pulse. So you can see, imagine that this is just one beat of an atrial ectopic, just one beat on this. Okay, it doesn't go any further. Any questions about that? Okay, so it's just trying to explain a concept to you. So this is one beat of an atrial ectopic. This is just another example of this for you to have a look. There's arrows here. So you see again that there's a P QRST. The QRST is exactly the same, but then you can see this P wave here that's being generated close to the T wave before it conducts again to the ventricles. Pause, P QRST again, and different P, and then another QRS, which carries on. So again, you see this down here. P QRST, another P wave, QRST. And there's one beat there that's very interesting, very negative. That's an ectopic beat on its own without a preceding normal beat. You can see this P wave there looks different to this P wave there. So again, this is just another example of an atrial ectopic occurring. So again, concentrate on the rhythm strip and see what try and describe what you see to yourself. Okay, so if you just remember, just look at the rhythm strip. We've got 5 beats here, 1, 2, 3, 4, 5, which seem faster than these beats here. And then before the P QRST starts again. But what's common again to all these beats is the QRST is the same shape. QRST is the same shape. What is different is the P wave. So in these 5 beats, the P wave is negative in the inferior leads. So lead 2, 3 in AVF, it's negative. And it's negative again here, but here it's positive, and back to how it should be in sinus rhythm. But in sinus rhythm, the rate is slower. Okay, and then negative beat again. So obviously this is not one beat. This is what we call an atrial run, or a short run of ectopic atrial rhythm. Ectopic means coming from a different source than the sinus node We can say that is the case because it's a negative P wave, and it's just 1, 2, 3, 4, 5. Heart resets itself back to sinus rhythm, sinus rhythm, sinus rhythm, sinus rhythm, negative P wave again. So ectopic beat there, just one beat before the edge of the ECG. So this is what we call an ectopic atrial rhythm, or 5 atrial ectopics together. It's not particularly fast. It's not really a tachycardia by definition because it's less than 100 beats, more than 3 large squares, but we call this an ectopic atrial run or ectopic atrial rhythm. So okay. Have a look at this ECG and concentrate on the rhythm strip along here. Okay, so we have a tachycardia. Okay, definitely. About 130 beats a minute. We have a narrow QRS. We can check everywhere else. Yep, the QRS is narrow. Okay. Is the rhythm regular? Yeah, the spacing between every QRS is the same. So a narrow QRS tells us that conduction from the AV node down to the ventricles is happening normally. Narrow QRS. Okay, are there any P waves? Yes. Look at the shape of these P waves. So they're very negative inferiorly. Okay, that's not sinus. Okay, that's coming from somewhere low down in the atrium, going away from the bottom of the atrium up to the top of the atrium, because the inferior leads are all negative. A negative deflection says that it's going away from that lead. It's going away from the bottom of the atrium. So the QRS looks the same on every single beat, and the P waves look the same as well. So this time we've got the P waves that are going exactly negative all the way along, firing off. This is firing off atrial tachycardia going down to the ventricles every beat. So this is focal and discrete. You check everywhere. All the P waves are focal and discrete, negative inferiorly. So this is a run of atrial tachycardia now. Atrial tachycardia. So what I've tried to say is you've got an atrial ectopic here, which is just one beat occurring on its own, atrial ectopic. This is an atrial run where there's more than one ectopic, but it's going in succession of 5 beats before it goes back to a sinus beat. And now we have an atrial tachycardia. We have a negative P wave conducting to every QRS. As the QRS is the same, the P wave is different and negative. So this is an atrial tachycardia. Okay, any questions? Okay, so we've gone through QRS being narrow, regular or regularly irregular, definite P waves, discrete, could be sinus tachycardia, it could be an ectopic atrial tachycardia, or less likely an AV reentrant tachycardia because of Wolff-Parkinson-White and accessory pathway. So have a look at a question. So does that mean the A tachy is due to an ectopic beat? Yeah, so it's just the ectopic beat. When it's just one beat, it fires once. When it's a tachycardia, it keeps firing, ding, 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 ding. So it keeps firing, and that's, I'm just trying to show you on the ECG. So it keeps firing, ectopic beat fires, ectopic fires from the atrium. This is driving the tachycardia, this fast beat. So this becomes an ectopic atrial tachycardia. Okay, does that explain that correctly? Yep, you're welcome. Great. Okay, so we're moving on. So have a look at this ECG, please. Okay, so we've got a bit of an artifact here, so don't worry, it's just the way the ECG has been recorded, so it's not anything going wrong. So if you try and have a look at the rhythm strip and see. So we have a tachycardia. So we have a narrow QRS. So again, our conduction from the atrium to the ventricles is normal, or from the AV node down is normal. That's what the narrow QRS tells us. Okay. So our next question, is the rhythm regular? Yeah, it's certainly regular. The spacing between every QRS is the same. In actual fact, the rate is about 150. So that's quite interesting. You've got two large squares, the rate is 150. Okay, are there any P waves? Yes, there are definite P waves. Are they discrete? Okay, so if I go to V1 and look at this, you might think it's discrete there. And then there's another one there, you see, and then you see two P waves like this. But now we need to go to the inferior leads to confirm that. And you can see, look at this. Can you see this wave? Almost looks continuous. It looks sawtooth. So you have to try and superimpose it. And you see it very well here along this rhythm strip. There's the flutter wave. So it's a continuous wave now. Looks slightly different here because of the T superimposed. And there's the QRS. But we have now a continuous wave. It's not focal or discrete. You best see it in the inferior leads. So this is an example of atrial flutter. And it's 2-to-1 conduction. So we know that there's 300 beats is 1-to-1. Every flutter wave is 300. This is going 2-to-1 because there's a rate of 150 between the QRSs. You don't necessarily need to say that, but this would be an ECG of a regular narrow complex tachycardia with flutter waves in the inferior leads, indicative of atrial flutter. Okay, so in this example, what I've done is just tried to show you again about atrial flutter, but slowed it down so you can try and make more appreciation of the flutter waves. Okay, so yeah, it's not a tachycardia because our QRS is not going fast. It's now 75 beats. 4 squares, 300 divided by 4 is 75. Okay, so yeah, it's not a tachycardia, but now the appreciation of, look, in V1, these probably look discrete. You probably might say they're discrete. But now look at the inferior leads, and where it's slowing down, no, it's definitely now continuous. This is not a discrete P wave firing off. Okay, this is much more continuous and fluttery. Okay, much clearly seen now compared to this example. Okay, so this is just another example of your atrial flutter, which is 4-to-1, 75 beats a minute. And yes, it's not a tachycardia. Okay, does everyone appreciate that? Any questions? So we also talked about trying to show you what variable conduction means. Okay? So, just going to try and get my cursor. So again, okay, it's another example of atrial flutter. Okay, so 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16. Yeah, 16. So 16 divided by 6 is not quite. It's about 96 beats a minute. So it's not quite a tachycardia. However, it's trying to prove a point for you that sometimes the rhythm can be conducting to the ventricles at different rates. So you might say this is regularly irregular, or the conduction to the ventricles varies. So you can see here that you've got the sawtooth pattern again inferiorly. So it's not discrete P waves. You've got a very small QRS here in lead 3. There's the QRS there. So it's quite hard to see, but otherwise in lead 2, you see a positive deflection, and you've got the continuous flutter wave here. But now if you look along the long rhythm strip, you can see the variable conduction to the ventricles. So here the conduction is 2-to-1, and now it goes out to 4-to-1, back to 3-to-1, 4-to-1, 2-to-1, 4-to-1. It's changing, so it's variable conduction because of how the AV node is working at this particular point in time. So in this point, the AV node recovered, it goes there. This one, it takes a bit longer to recover, and then there's the QRS conduction to the ventricle. So this is just an example again of atrial flutter, but it's trying to prove the point of variable conduction to the ventricle, as evidenced by a regularly irregular QRS, but a narrow QRS nonetheless, but regularly irregular. Okay, does everyone any questions about that concept? Okay, so we've gone through this left-hand side, QRS narrow, regular, and regularly irregular, definite P waves. They may be discrete, they may be continuous and regular sawtooth pattern. And again, best look in your inferior leads for this, for atrial flutter. Discrete P waves could be sinus tachycardia if they're the same shape as sinus rhythm, and ectopic atrial tachycardia, or AV reentrant tachycardia, which is the Wolff-Parkinson-White. Okay, have a look at this example, please. So ask yourselves the questions. This is a tachycardia, yes. Is the QRS narrow? Yes. So the QRS is narrow. This means that there's conduction from the AV node down to the ventricles is normal. Okay. Is the rhythm regular or irregular? The spacing between every QRS and the rhythm strip is different. The spacing is variable. It's irregular. So this is an irregular rhythm. Okay. Are there any P waves? You cannot see any definite P waves. So we go to V1. You really can't see any P waves. So that might be fibrillation where it's slowed down just momentarily. That could be a fibrillatory wave, the bumping there. It's quite difficult to see. The other thing here is if you look in an individual lead, let's look at lead V6, for example. What you now see is the varying QRS heights. Okay, so varying QRS heights. The heights of the QRS are not the same. If you look at the baseline, they vary in heights. And there's just another slowing there that may show possible fibrillation. Okay, so this is an ECG of atrial fibrillation with fast ventricular response. So it would be the fact that, you know, it's an irregular rhythm. The QRS heights vary within a given lead. Any given lead, the QRS height is varying. It's getting taller and a bit smaller there. Within a given lead, even in lead 1, the heights vary. So that just means the conduction of the AF hitting the node is varying every time. In lead 3, we can see the same varying QRS heights, and that's an ectopic beat. Okay, so this is atrial fibrillation. Okay, have a look at this one, please. So is this a tachycardia? Yes. Is it a narrow QRS? Yes. Is the rhythm regular or irregular? Clearly irregular again. Okay, so we need to think about, is this atrial fibrillation? So you can see now much more clearly in V1, the best place to look is a very variable baseline. This is not atrial flutter. This is not flutter. This is coarse atrial fibrillation. This is not continuous or fluttery enough. So this is, again, having a look at the leads. The QRS heights vary within a given lead. So this is lead 2. Let's look at the QRS heights. Yeah, it goes up and down a bit. Okay, down and up. So that's very variable QRS heights, again, indicative of atrial fibrillation. So I've just shown you this example just to show you in V1, we're trying to look at this fibrillatory activity to confirm that this is atrial fibrillation. Okay, so we've just done QRS being narrow, irregular, no P waves, variable QRS amplitude with no P waves, atrial fibrillation. Atrial fibrillation. Okay, have a look at this example. Okay, so again, we have a tachycardia here. Okay, it's very fast, probably over 200 beats a minute. We have a narrow QRS, so the QRS is narrow. Again, the conduction from the AV node down to the ventricles is normal. Okay, we have a regular rhythm. The spacing between every QRS is the same. Okay, so it's regular. Now we're looking at the heights. If you look at the heights of the QRS, they're pretty much within a given lead. The heights of the QRS look the same, and they match. If you just scan, all of them match. The slight uplift here in the baseline, I agree, but generally on the whole, they are very regular and the same height within a given lead. Okay. Are there any P waves? I can't see any P waves. I think this is a T wave because that's too big to be a P wave. Okay. These are T waves. And so this is what we call a narrow complex tachycardia, a regular narrow complex tachycardia. Okay. Now, an actual, oh, sorry, pardon me. Basically, in actual fact, this is AV-nRT. Now, you wouldn't be expected to get this. The reason why this is AV-nRT is that if you actually look, this is the P wave buried in V1. That's the P wave. That's the simultaneous activation of the atriums and the ventricles together. So there's a little bump there as the P wave afterwards. You're not expected to get this. So in the situation, and you can see this bump there, there's the P wave just there. And that's probably a P wave just buried there, just after the QRS, just in case, you know, wanted to try and see. But you need to make a diagnosis here of a regular narrow complex tachycardia. And obviously your management of this depends on their A2E. And if their blood pressure is exceedingly low, then NICE guidance suggests that you electrically cardiovert these patients. Alternatively, you can do the Valsalva maneuver, get the patient to do the Valsalva to try and increase vagal tone to terminate the rhythm, which is dependent on the AV node. So that's why we say atrioventricular nodal reentrant tachycardia. It's dependent on the node. So if you can get rid of the node momentarily by increasing vagal tone or giving adenosine, which will travel in the body, will get all the way to the AV node and block the slow pathway in the AV-nRT circuit. Okay, so this is a regular narrow complex tachycardia. There are no P waves apart from, if you look carefully there, you're not expected to get that. Okay, have a look at this example, please. Okay, so again, we've got a tachycardia. We have a QRS that's narrow. Okay, conduction from the AV node down is the same and normal every beat. There's a regular rhythm, spacing between every QRS is the same, so it's a regular narrow complex tachycardia. Are there any P waves? No, these are all T waves. That's a T wave, that is a T wave. Okay, not a P wave. So there really aren't any P waves at all that are discernible. And so again, this is another example of a regular narrow complex tachycardia. I don't think this is AV-nRT, but there are no P waves. So this is likely to be AV reentrant tachycardia in the presence of an accessory pathway or Wolff-Parkinson-White going backwards. So this is why I've tried to draw this diagram for you. So, okay, so narrow complex tachycardia, which we're doing tonight, so it travels down the AV node, down the bundles, back up the pathway. And we're just putting the pathway here for argument's sake. The pathway can happen anywhere between the atrium and the ventricles, anywhere, but most likely 70% of cases are at the lateral mitral valve annulus. So conduction goes down, back up the accessory pathway. Because it's going down the AV node, the tachycardia is a narrow complex. Okay, and in this example, you can see some activation of the atrium. There is a little bump here in the T that would signify the P wave or the activation backwards of the atrium by the tachycardia, just in this example. But it's a regular, narrow, complex tachycardia. However, if we now change the rhythm going the other way, so if it's going down the pathway from the atrium to the ventricles and back up the node, okay, around like this, then now we have a broad complex tachycardia, but in particular, you have the delta wave. You only see a delta wave when you have conduction forwards over the pathway from the atrium to the ventricles. So in sinus rhythm, you have it over the pathway. In this tachycardia, which is broad and regular, you see conduction over the accessory pathway like this, and hence you see a delta wave. Any questions about that? So we'll go through broad, like I say, broad tachycardias next week. But again, just trying to show you the difference between why in Wolff-Parkinson-White with an accessory pathway can you get narrow complex tachycardia and also broad complex tachycardia. It's by virtue of the way with the delta wave. It's by virtue of where the tachycardia is traveling. Okay, so we've done most of QRS narrow, regular, no definite P waves, narrow complex tachycardias, AV nodal reentrant tachycardia, AV reentrant tachycardia, less likely ectopic atrial tachycardia. You might get an ectopic atrial tachycardia where you don't see the P wave. Any questions at all? Okay, so we'll go on to Kahoot. Do this one. Okay, so the first 9 questions are sort of concepts, and then I've got the ECGs to show you from question 10. Okay. Yeah, so P waves, QRS, and delta waves are most important. Okay, these are the most important waves. Yeah, so it's the AV node. AV node is the final common pathway. All of them go down to the AV node. Yeah, V1 is the best lead to look for bundle branch block. V1 is the best lead. Okay, if it's negative, remember it's left bundle branch block. If it's positive in lead V1, it's right bundle branch block. Of course, you may look at AVL to look for left axis deviation, but again, it's not the best lead. Yeah, so if QRS is positive in V1, bundle branch is right bundle branch block. Okay. Yeah, so yes, they can. So all the SVTs I talked about today can present as a broad complex tachycardia because they would be pre-existing bundle branch block. I'm probably going to answer the next question. So I'm just going to be careful. Okay, so it's what we call a functional bundle branch block. I didn't want to open and answer the last question. So aberrant conduction normally means the right bundle will switch off during tachycardia. Now we'll talk about it more next week, but you can have evidence of aberrant conduction when there's very fast rhythm. The heart sort of says, right, okay, the right bundle is going to switch off. You will have evidence of right bundle branch block during the tachycardia. In particular, in V1, you'll have the small bunny rabbits here before the big bunny rabbits here. That tells you it's right bundle branch block. And when the heart is fast, it's bundle branch block. When the heart slows down a little bit, it will go back to being a narrow complex tachycardia. We'll talk about that next week as part of broad complex tachycardias. In Wolff-Parkinson-White, do you always see a delta wave in a patient with tachycardia? You always see a delta wave? No, they can have narrow complex tachycardias, okay? So you don't always see a delta wave. Don't always see a delta wave. You only see a delta wave when the conduction is going, again, I'm not going to open my Yeah, so it's down the AV node, back up the pathway. You're going to have a narrow QRS, whereas down the pathway, remember, over the pathway and back up the AV node would be a delta wave. Okay. So remember, you only see a delta wave when it goes down the pathway from the atrium to the ventricles. Any rhythm, it could be atrial fibrillation, atrial flutter, or a tachycardia, now complex tachycardia, sorry, a broad complex tachycardia, but by virtue of going down the pathway from the atrium to the ventricle, you will see the delta wave. You will see the delta wave. Okay, let's just go back. So let's just show you that again, okay? Just to try and explain to you. So you have your accessory pathway. It overlies the atrium and the ventricles. So it connects the atrium and the ventricles in addition to the AV node. So when there is a narrow complex tachycardia, the only way this can travel is down the AV node, and it manages to come back to the atrium because there is an accessory pathway conducting this way. Okay, so therefore we have a narrow QRS tachycardia, and in this example there is a bit of a P wave there. Okay, so this is AV reentrant tachycardia, AV reentrant tachycardia. Alternatively, we have conduction that's going the other way around in the same patient. It's going the other way around, so it comes down from the atrium over the accessory pathway to the ventricles, and if it does that, we will have a delta wave. Okay, and then it manages to travel backwards this way, back over the AV node and up to re-enter the atrium, hence AV reentrant tachycardia as well, but slightly different. It's called antidromic because it's going the other way, antidromic forwards over the pathway. This is orthodromic, which is down the AV node and back up the accessory pathway. I'm just hopeful, have I clarified that for everybody? Any questions? So effectively, you only see the delta wave when it's going forwards, conducting any signal going from the atrium to the ventricles. So in sinus rhythm, from the sinus node down the pathway, you will see a delta wave with a short PR interval. Okay, this is the ECG for questions 10 to 16. So look carefully. This is question 10 to 16. So questions 10 to 16 now. Okay, question 10. Yeah, very good. Narrow complex. The QRS is narrow, very good. AV node conduction down the AV node to the ventricles is normal. So it's definitely irregular. It's definitely an irregular rhythm. Look at the spacing between every QRS is very variable. There's a bit there where it goes a little bit faster, but it's still irregular. Yeah, I think they are variable. If you try to look in a given lead, it's a difficult one in this one, difficult one, but I think they are variable. Yeah, so atrial fibrillation. So there's no P waves in the example. So you got just fibrillatory activity there in between each QRS. Okay, there's no definite P waves as well. So yeah, atrial fibrillation. Yeah, very good. Anticoagulant is the most important treatment, try and prevent strokes. Well done. Yeah, so it's within 48 hours of the onset. We've got to be clear that the patient knows when it started and within 48 hours, okay? Otherwise, it can't be any time, okay? Because you need at least 4 weeks of anticoagulation and not 2 weeks, okay? So it's got to be within 48 hours of the onset, okay? If patients come in and they don't know how long they've been in AF, then we slow them down with medication. Then we give anticoagulation for a minimum of 4 weeks before we can safely then bring them in as an outpatient to cardiovert them under conscious sedation. There's one more question. Yeah, so there's no routine monitoring for DOACs. You don't, used to do INRs with warfarin. Warfarin's still used for metallic valves, but DOACs, you don't have to go and have a blood test for a DOAC every week, checking the levels at all. You probably need a blood test every 6 months or a year, depending how good your kidneys are, to make sure your kidneys are still functioning well, because these drugs are excreted by the kidneys, and the dose may need adjusting if your kidneys are deteriorating. Okay, so question 17 to 22. I'll give you some time to look at this one. 17 to 22. 17 to 22. Very good. Yeah, narrow complex, narrow complex. Put a pencil over it and it will disappear. Yeah, so this is regular. Look at the spacing between every QRS is the same, absolutely the same. Okay, the QRSs look the same. You just glance at them. The heights of the QRSs are the same. There's a bit of artifact there, but yeah, I think there aren't any definite P waves. I suppose, does it really matter with the treatment of the patient? No, because you'd still do the Valsalva maneuver. If that doesn't work, carotid sinus massage. If that doesn't work, you could give them adenosine. So it doesn't quite matter for the treatment really. But yeah, I think there's no P waves in there, no P waves. Yeah, I think this is what we call a narrow complex tachycardia. So if there's no P waves, it can't be atrial tachycardia, it can't be flutter waves, and it's not atrial fibrillation because it's not irregular. It was a regular narrow complex rhythm. This was a narrow complex tachycardia. Now, possibly there may be some P wave just buried in there. I think when I've looked at this, I think it might be AV and RT, it might be. I'm just trying to think. What was, 22. Yeah, so Valsalva. Last question on this one. Yeah, so adenosine, quick acting nucleoside analog, goes all the way to the heart, from the arm into the lungs, in the bloodstream, back to the heart, and then goes to the AV node to stop AV node. The AV node stops working as it acts on the slow cardiac action potential and blocks the AV node working momentarily to terminate the tachycardia, and the sinus node takes over. Okay. Okay, so questions 23 to 26. 23 to 26. Okay. Yes, this is narrow. We're looking at the QRS. It's a narrow QRS here. Narrow. Okay. It is negative in V1, but that doesn't mean to say it's a broad, QRS. Okay. So it's got to be broad. It's got to be over 3 large squares to be broad. Yeah, so it's a regular rhythm, regular. Spacing between every QRS is the same, regular. Yeah. So look here, you can see there are P waves. And you have to ask yourself, are they focal or discrete, or are they continuous and fluttery? Yes, this is atrial tachycardia. If we have another look, I'll show you the ECG again, actually, because this is the last question. Let's just go through that. Looking at the ECG, you should see the ECG now. I've tried to blow it up for you. Let's go in a bit more detail. So we have a tachycardia, okay? We have a narrow QRS, We have a regular rhythm. The spacing between every QRS is the same, regular. Do we have any P waves? Yes. Look at the P wave, it's very discrete. It's not fluttering along there. It's very discrete and focal. So this is firing off. And in lead 2, we see the P wave is negative. So that's not sinus tachycardia. Okay, that's an ectopic atrial tachycardia. This is firing off, going to the ventricles, firing to the ventricles, firing to the ventricles, firing to the ventricles. And it's the same P wave shape all the way along. And the QRS is the same all the way along as well. So conduction down from the AV node is the same every beat. Okay, and so this is the last one. A little bit of a curveball. Let me just make it smaller. Let's just see, in preparation for next week, how you do on this one. So this is the last questions, 27 to 32. Okay, last questions now. Yeah, very good. So it's clearly broad now. You're seeing what a broad, this is all broad. It's a broad rhythm, definitely broad. QRS is greater than 3 small squares. Yeah, so it's regular, very good. A regular rhythm, the spacing between every QRS is exactly the same, very good. Even the heights of the QRS look the same for a given lead. So in V3, the heights look the same, they all match. So the answer is no. Yeah, it's not typical. It's not typical. So you look at V1, okay, you don't have the bunny rabbit's ears going the right way around. It's the other way around. So you've got a big bunny rabbit's ear, then the smaller one. We'll have a look at that ECG. So it's not typical, not a typical bundle branch block pattern. So no, there is not a delta wave actually in this one. It's not a delta wave, not a delta wave. Yeah, so VT is the right answer. Okay, so you have to try and ask yourself, there isn't bundle branch block. So it's not pre-existing bundle branch block. So we didn't have right, it's not right bundle branch block. Right bundle branch block occurs with aberrant conduction, which is the rate-related functional block in the right bundle during tachycardia. It's not VF, so it's VT, irregular broad complex tachycardia, regular broad complex tachycardia. Last question. Yeah, so something called dissociation. Yeah, so you have the ventricular tachycardia firing, and then you're looking for sinus beats, P waves. So we'll talk about more of that next week. So it's VA dissociation. So it's the opposite of complete heart block. In complete heart block, there are more P waves firing, and there's no association to the ventricle. Whereas in VT, there are QRSs firing, but there's no association to the P waves in the atrium. Delta's won it. Well done, Delta. Okay. So that's the any questions at all? Can I show explain anything? Show any other ECGs again for you? Okay, we'll stop the recording.